G'day guys, this is on calcification, friend or foe. There's been a lot of controversy in the carnivore community in terms of calcification, what causes it, why we see in the recent research that was basically done, epidemiological studies, and people have noticed there was potentially an increase and all that. You have to remember these are people that already had some level of calcification. So now, what sort of calcification will they have had on a non-species appropriate diet? A lot of them would have had, soft calcification. So when you have soft calcification, the body on a species appropriate diet will basically deal with that by increasing the calcification to stabilize that atheroma. The body is not stupid. It uses calcium, like it uses calcium to basically suppress. Vitamin D brings it in, uses calcium to suppress, like herpes, for instance, and things like that. That's why you usually get an outbreak on your face and all that if your vitamin D levels are much lower in winter. So there are reasons why the body uses calcium. So it will make something like plaque, which is far more stable, and that's the important part of it. And so initially when you go on that, it will actually, to decalcify, you have to basically use methaquinone for high doses of it, because it's the only one that actually has the right structure in order to capture and remove. And under those sort of circumstances, in a low inflammatory state, you'll also clear away a lot of the debris as that happens. In a highly inflamed state that these people were, what you may notice is when you're on a diet which is a species appropriate, you may notice these inflammatory markers coming down, but calcification can go up. Now, if you don't have any soft plaque, it's not going to happen. Like, for instance, Sean, he never had any soft plaque. So when he came off low carbohydrate type diets and went on a carnivore diet, and then did a test much later on, after he'd already been on a carnivore diet a number of years in low carbohydrate state, he never had, and basically he never acquired any new stuff. So if there was soft plaque there, then it would calcify and it would have shown up. But it's not that basically the calcification is a problem. It depends the drivers, why it's happening in the first place. So the initial stuff is going to happen because of inflammation in the body, because of random cycle activation, seed oils, all this sort of stuff that causes that inflammation. Then the body actually, will basically use Lp(a), which is a modified version of LDL, and will go there and try to stitch up all that and use calcium and all that. And what you do is initially you get all these small levels of calcium here and there. It's a sort of like a rough stitch up. But if you keep on inflaming that, you will get more build up of that soft plaquing. What a species appropriate diet does will stabilize it, will actually bring in more calcium and remove more of the actual lipoproteins. So it'll actually get rid of the lipid stuff and actually put more calcium there to stabilize it, which is a good thing. Then you can use methaquinone 4 to actually remove that calcification, and then you've cleared the artery. Got it? That's how it's supposed to work in that regard. So the body knows it's been doing this for a very long time. It uses uric acid as an antioxidant, it uses Lp(a) to deal with endothelial damage. So when you get endothelial damage, it's like the body and other tissues. You cut yourself somewhere on the skin or stuff, and you've got a lesion or whatever. What happens is you get all this macrophage rushes in, all this sort of stuff, clotting factors, and actually seals it up and clears up all the mess, and uses calcium as well and all that. And then over time that heals and clears up. That's what it's supposed to do. Now, if you're in an inflamed state continuously and causing damage and all that, you'll get continuous calcium being put into there to stabilize all that. And if you don't get enough calcium, then you'll have more soft plaque, and that's the sort of stuff that will rupture. Soft plaque atheromas are what kills people, not calcified atheromas, which are stable. There is a fundamental difference between the two, and people need to understand that in that regard. So when you go on a species appropriate diet, what happens is you're bringing in more calcium because of the high protein, and at the same time that calcium is going in there and replacing all the soft plaquing, which is a good thing. And that's what's supposed to happen and stabilize all that. And then with high menaquinone, you can actually remove that over time. You can do it slowly on a species appropriate diet, or you could do it more rapidly with high supplementation like I've done. So it depends on the situation, but fundamentally that's how it's supposed to work. Now if you're on a species appropriate diet from birth to death, you would not have this sort of stuff. If you've been on a low carbohydrate state, you never really eaten junk food and garbage and all that like Sean hasn't. Even after many years of low carbohydrate and now carnivore, he's got 0. And that's normal. But the people that basically on these studies are basically people that are already, are on a SAD diet. Basically, that's what these people picked, because that's usually the volunteers. You don't find a lot of healthy people unless they go on these studies. It's usually primarily people, your regular people that are already have underlying health issues and all that, and they bring them in to try a diet to see does it actually help improve their health markers. Now all the other health markers improved, but the only thing that didn't was actually this increased calcification. And I'll explain why, and why it's a good thing, because it basically means those soft plaques are turning into hard plaques, which basically are more stable and prevent potential rupture of atheromas, soft atheromas, which can basically kill. So let me share the screen. Okay, so calcification in atherosclerotic plaque, vulnerability, friend or foe. Calcification is a clinical marker of atherosclerosis. It's a clinical marker, it's not a causal. Okay? The review focuses on recent findings on the association between calcification and plaque vulnerability. Exactly, vulnerability is the actual word. Calcified plaques have traditionally been regarded as stable atheromas. Got it? As stable atheromas. This is not old stuff. This is not new stuff in the literature. When you look at an atheroma, if it's quite calcified, it's stable. If it's not, and it's got like non-calcified, so those causing stenosis may be more, so the stenosis type, which is the problematic stuff, are more, so those causing stenosis may be more stable than those non-calcified plaques. So in the stenosis itself, you're going to get two types. So as you got that where it elongates and sort of changes its shape, the stenosis, you can actually even have either stable, calcified, or non-stable plaques, which are called soft plaques. And you can't really see them when you do that test, that calcification test. Anyway, with the advance in intravascular imaging technology, which is a CAC type stuff and all that, the detection of calcification and its surrounding plaque components have evolved, the CAC. Now, they're a double-edged sword. On the one hand, I've never been a big fan of CAC. I think it depends where you're at in your journey, and higher numbers don't actually mean it's worse. It's only progression, as Ivor would say. But the issue is progressions can sometimes be a benefit, especially if you're coming on for an inflammatory diet or not. Microcalcification and spotty calcification represent an active stage of vascular calcification correlated with inflammation. So when you're at the early stages, when you've got a lot of inflammation in your arteries and you're getting, damage to your endothelium, this vascular calcification will happen, and it'll be also microcalcification, small amounts of calcium, and spotty calcification. So it's still basically being built to basically really stabilize that. Whereas the degree of plaque calcification is strongly inversely related to macrophage infiltration. So basically, when they're saying calcification, plaque calcification is strongly inversely, which is the opposite. So you will have more macrophage infiltration. That is an inflammatory marker. So when you actually get the atheroma more calcified and stable, your macrophage goes down. That means your inflammation goes down, which is a good thing. Asymptomatic patients have a higher content of plaque calcification, got it? Asymptomatic patients than in symptomatic patients. So people that have got symptoms and potentially could have ruptures are people that have got less calcification, not more. Got it? The effects of calcification may be biphasic. Plaque ruptures have been shown to correlate positively with the number of spotty calcification. Got it? Not enough. And inversely with a number of large calcifications. So the complete opposite. So if you've got patchy, a lot of soft plaque with very little calcification, it's actually less stable, more problematic. There's been a certain stage of calcium deposition that may be more atherogenic. So at certain stages, the stages change. So at certain stages, it has to do with really the composition of the atheroma there. Is it basically more calcium based or is it less calcium based? That's what really, it's not the progression of calcium. That's where I think a lot of people have got it wrong, including Ivor. It's not the progression, it's really at what stage, is it stable or not? Very important. Okay, plaque ruptures. We'll move on. There has been certain, maybe more atherogenic. More superficial calcifications are independently associated with plaque ruptures. Got it? So when you don't have something, so an atheroma calcified enough, they are more prone to ruptures. And intraplaque hemorrhage, which may be due to the concentration and asymmetrical distribution of biological stress in the plaque. So this is where you may have higher blood pressure and it's creating shearing forces on the atheroma, which could potentially cause its rupture. Something that has more calcification is going to be more stable and can withstand those shearing forces. So that's another issue in itself. Conclusively, calcification of different amounts, size, shapes, and position may play different roles in plaque homeostasis. The surrounding environments around calcification within plaques also have impact on plaque homeostasis. That means, what's the amount of macrophage? What amount of inflammation is there? Is it basically stable and still building up? Is the actual inflammation outpacing the ability to stabilize it, where you actually end up with this sort of spotty calcification because you're still inflaming the area and still building up, where little LP(a) has to rush in and try and stitch it all up and hold it together, and you end up with more soft plaque. So is that actually happening, or are you stabilizing it? Very important. So, when you get into plaque homeostasis, it's a very different ballgame. The interactive effects of these important factors of calcification plaque still await further study. There's a lot that we need to understand in terms of that. Three main types: vascular calcification, medial arterial calcification, interim calcification, and infant calcifications. So that is medial arterial calcification is often seen in age, diabetic, mellitus, and chronic renal failure patients. However, interim calcification is more frequently associated with atherosclerosis and has regarded as a positive and degenerative process. It has been recognised as an active and self-regulated process. Interim calcification is akin to multi-step process of bone formation and is controlled by complex enzymatic and cellular pathways. Anyway, now let's just go to the next one, so that if people want to read it further, they can actually look into that. Now, the influence of calcification factors and endothelial dysfunction factors and the development of unstable atherosclerotic plaques. Yes, a bit of a tongue twister. This is out of Russia. Anyway, this study aims to evaluate the changes in markers of calcification and the endothelial dysfunction during the development of calcification and instability of atherosclerotic plaques, and to identify associated calcification factors with the formation of unstable plaques. Method: we analysed 44 male patients with coronary atherosclerosis who underwent endarterectomy in the coronary artery during coronary bypass surgery. The intramaterial intermedia was examined during histological and biological methods, and the stability and calcification degrees of atherosclerotic plaque were assessed. Okay, in the homogenates, the tissue samples, and in the blood concentrations of osteoproteogenesis, osteocalcin and osteopontin and osteonectin, and monochemoattractants, protein type 1, soluble vascular cells, adhesive molecules, and E-selectins were determined by enzyme immunoassays. Now, a lot of these things you've probably heard: osteocalcin, bones and stuff like that, very much regulated by, and many of these other ones, these enzymes are all regulated by fat-soluble vitamins. Okay, so just keep that in mind about these enzymes. Some people may not know the other names, unimportant. Just remember that these are regulated by fat-soluble vitamins. Results: unstable atherosclerotic plaques prove to be calcified more frequently, 80.4 of plaques, and then stable ones, 45. Osteonectin and E-selectin and VCMA1 levels were lower in unstable plaques and plaques with larger calcification deposits. Got it? Osteocalcin content increased with the increase in the size of calcification and deposits in the plaque. Again, this is regulated by minoquinone 4, vitamin K2 basically. Okay? Blood osteocalcin concentrations directly correlate with osteocalcin concentrations in atherosclerotic plaques and was high in the bloods of patients with calcified plaque in coronary arteries. Conclusions: as a result, provides a base for further research in the suitability of the calcin as a potential biomarker of an unstable calcified atherosclerotic plaque in the coronary artery. So, remember what they said here? Were lower. That is actually telling me that there's less fat-soluble vitamins regulating these. That's why, because remember, they are transcripted, so less stable plaque is less fat-soluble vitamins because they transcript the proteins. And most of you have probably heard about osteocalcin, vitamin retinol, and vitamin D, and then they are activated by, used to be Activator X, the Activator X that Western A. Price used to talk about. Well, we know now it's vitamin K2, and basically in the old days it was minoquinone 4. Okay, so we know when these things, these enzymes are basically transcripted and activated, and much higher, you've basically got more stable, rather than when they're lower, less stable. So when we initially, so what happens is, calcium is a stabilizing thing. It's not your enemy. It's the body trying to calcify that to try and really prevent it from becoming dangerous in the body. When it's not calcified enough, that's a problem. And when it's quite calcified, then it will heal. It'll heal the endothelium behind, and then if you've got enough menaquinone 4, it will clear away that calcification. That's how it's supposed to work. You basically come in, you stitch it all up. So I'll just stop this for a sec so I can actually chat a bit. You get an injury in your artery. The body rushes in, stitches it all up with, LP(a) is upregulated. So people that don't have vitamin C basically use, all animals that don't endogenously produce vitamin C will actually use uric acid as an antioxidant, and they will use LP(a) as a repair mechanism. So it goes into there, repairs that, and remember it's a modified version of LDL with this little tail, and it stitches it all up, and ties it all together and puts a bit of calcium there and all that. And over time, the body will actually calcify that to stabilize it. And when it calcifies it very tightly and quite a bit, then it removes the soft, the lipid stuff that actually the LP(a) brought into the binding, that initial binding stuff gets removed, cleared out. And then you've got this plaquing, calcified stable plaque, and that basically then allows the endothelium behind that part to heal. And once it's healed, then the body comes in, because remember, you've had an injury, and you're not inflamed because you're on a species appropriate diet, and then it will come in and clear all that debris away, all that calcium away. That's what menaquinone out of soft tissue, that's what it does. It has a capacity to do that. The other menaquinones don't. It's only menaquinone 4 that has that additional structure, protein structure, that can actually latch on and take the calcium and put it in the bones. Got it? That's how it's supposed to be. So excess calcification is not the problem. It is basically inflammation that leads to plaquing that then requires the body to stabilize that. Got it? And then when it's stable, and you're in a, remember the other stuff that we looked at before, when it's stable, macrophage proliferation goes down, is inversely. Got it? So more calcified, better share that. Remember the other one that we were looking at? So more calcification is inversely, which is the opposite, related to macrophage infiltration. That means all that initial inflammation, all that initial scaffolding and soft spotty calcification, when it's quite calcified and stable, the immune system eases off. As long as there's no new inflammation, that means you're not having seed oils and a whole lot of other garbage in there, glycating factors and sugars and all that. But if you're back to a species appropriate, it'll calcify, so calcification will increase. It will allow the healing. It's a bit like on your skin. What happens to your skin when you get a cut? You get this sort of, rough tissue and all that. That's like a calcified, it is, and it's actually, there is calcium in that, and that basically then allows it to heal, and then it clears away all the debris. That's what's supposed to happen. Unfortunately, most people are calcifying themselves, and the body is calcifying to stabilize it, and then continually adding to the damage. So when you do these short-term studies of people that have already got soft tissue, what do? They calcify it, which is a good thing because it's stabilizing it. The best thing that could have happened to these people is they calcified and stabilized their atheromas, which were unstable, soft, soft plaques, very dangerous and can rupture. Are very, very dangerous, especially when you're inflamed and building up, you know, these sort of soft plaques with, you know, spotty calcium and all that, not insufficient calcium because you don't have enough of the fat soluble vitamins to run all those enzymes to stabilize. That's what happens. Anyway, let's get back into it. So anyway, so that's that basically, and that is why, you know, it is really important. So they are looking at using this as a biomarker. Well, I would say if you want to fix this biomarker, you don't need drugs, because that's what they're going to do. They're going to invent some fucking drug which basically is not going to really help anyone. It's just going to make things worse and derange the stuff. When they see these biomarkers, then it means these people are deficient in fat soluble vitamins to regulate these enzymes properly. Anyway, let's move on. Now, go away. How does calcification influence plaque vulnerability? Insights from fatigue analysis. Calcification is commonly believed to be associated with cardiovascular disease burden, but whether or not the calcifications has a negative effect on plaque vulnerability is still under debate. Yes, well, you got a lot of vagoons out there still debating the thing and a whole lot of other idiots. But fatigue rupture analysis and fatigue life were used to evaluate the rupture risk. And that's the key thing, rupture risk. An idealized baseline model containing no calcification was first built. Based on the baseline model, we investigated the influence of calcification on rupture paths and fatigue life. And by adding circular calcification and changing its location within the fibrous cap area, results show that 85% of calcified cases increase the fatigue life up to 11.4%. For rupture paths, 10D, far from calcification, the life change is negligible. And that's a problem because you're more likely to not have longer lifespan of stable atheroma, which is really important. Calcification close to the lumen increases more fatigue life than those close to the lipid pool. Also, calcification in the middle area, the fibrotic cap, it's the middle part, increases more fatigue life. So, you know, than those in the surrounding area. Conclusions: calcifications may play a positive role in the plaque stability. Got it? The influence of calcification only exists in a local area. Calcification close to the lumen may be influenced more than those close to the lipid pool, and calcification in the middle area caps are seemingly influenced more than those in the surrounded area. And that's really, that middle part is where the ruptures happen. You need to stabilize that, which shows quite clearly that when you actually increase the capacity to basically calcify, you stabilize and prevent ruptures. Anyway, effects of calcification on the mechanical stability of plaque based on three-dimensional carotid bifurcation model. The study characterized the distribution of components of plaque structures by presenting three-dimensional blood vessel models with the aim of determining mechanical properties due to the effects of lipid core and calcifications within a plaque. This is really important. You know, we're talking about lipid core, we're talking about soft plaquing, very dangerous, and calcified plaque, not so dangerous. The more it is, the more stable it is. We don't want to be building up more, but we have to, this is the nuance. The nuance is, if I've got low inflammation but high calcification, that means I've got stable atheroma. If I've got high inflammation and low calcification, that's actually more dangerous. It means that I'm building up more and more atheroma, which is soft plaque, which basically means I could have multiple ruptures and potentially die from heart attack. Way more dangerous. This is why people go and actually get tested and say, oh, you look fine. We don't see anything. You look fine. The old, the Ethelstein and all these other groups that were doing all these sort of tests and stuff like that, who don't understand physiology the way it works, they'll say, oh, it looks all fine. As I said, I'm always here to basically surprise you about these things and literally slay certain sacred cows. Yes, that's the no BS mission that this channel has, and really explaining how your physiology works and supposed to work. Numerical simulations have been used to answer how cap thickness and calcium distribution in lipids influence the biomechanical stress on the plaque, and that is really important. So the biomechanical stress, obviously blood pressure can be an issue. A low carbohydrate diet tends to lower the level of stress, biomechanical stress, which is important in terms of reducing the amount of this problem. But at the same time, we need to understand the actual physiology and what's happening. Modelling atherosclerosis plaque based on structural analysis confirms the rationale for plaque mechanical examination and the feasibility of our simulation model mean for variation predictions of the model of atherosclerotic plaque. Model typically requires examination of bona fide atherosclerotic lesions to analyse a more accurate plaque rupture. Fluid structure interactions is applied to three-dimensional blood vessel keratin bifurcation modelling, a patient-specific pressure variation. So obviously pressure variation, we're talking about blood pressure, is applied onto the plaque to influence its vulnerability. Anyway, results: modelling of the human atherosclerotic artery with varied degrees of lipid core, which is that middle part, elasticity, fibrous cap thickness, that means how much calcium is in there and how much soft plaque is in there in that middle part, and calcification gap, which identifies at the distance between the fibrous cap, that middle part, calcification agglomerates, forms, and the basis of our rupture analysis. So they're looking at the morphology and the distribution of calcium and how that will form and how the rupture will, they'll analyze that. Infinite element analysis shows that calcification gap should be conservatively smaller than its threshold to maintain plaque stability. The results add new mechanistic insights. Yes, they do. And methodological sound data to investigate plaque rupture mechanics. Structural analysis using three-dimensional calcification model represent a more realistic simulation of late-stage atherosclerotic plaque. We also demonstrate the increase of calcium content. And is coupled with a decrease. So the more calcium you've got, the more decreased lipid core volume. Got it? Decrease in lipid core volume can stabilize plaque structurally. So if you've got in those atheromas, basically what it's saying, if you've got less lipid content and that initial LP little a and then the lipid content that's actually stitched it all up is removed slowly and replaced with calcium that stabilizes it, yes, your calcium levels will go up. But as long as your inflammation comes down and you're not actually adding more damage, that will heal behind the calcium things. And if you're getting enough fat-soluble vitamins, especially menaquinone 4, it will slowly clear it away. Now, depending on the thickness of that calcification, how much damage initially, so if you've come from a SAD diet, see, normally, if you were on an ancestral diet, you may have had a little tear, bit of damage here or there. It would have calcified a bit, just a small lesion or whatever, and then it would have been cleared away eventually in a couple of months. No issue whatsoever. But we don't live in an ancestral world. We live in a world eating seed oils, refined sugars, a whole lot of shit. We're just inflaming and creating massive atheromas. Got it? That's the difference. And then they can't elongate and actually stretch anymore, and so they start caving in on themselves and actually making it even more vulnerable and unstable, this actual structure itself. Even with a lot of calcium in it can't really manage it. That's why you do eventually, when you've got very high level, very small, you know, openings, and you've got a lot of stuff there, that is very dangerous, extremely dangerous, for a rupture in that regard. So, and even if you've had bypass surgery and all that, that can still be a danger. Just because you've bypassed the problem, it doesn't mean it can't rupture. It can still rupture, you know, so you can still get a problem. You may not have the tissue affected, but you can still get a lot of debris and stuff like that that can cause streaking through the a number of other blood vessels, clogging those up potentially and causing problems and inflammation in those as well. So it's risky. Stable anginas are really important. Calcification does that. I said I'll surprise you, you know, because a lot of people haven't talked about this and don't understand this. There is science in this, but it's being ignored, unfortunately, and even Ivor is a bit on the wrong side on this one. I think he needs to have a relook at this sort of stuff. I think that doing calcium scores is an important thing, but it needs to be looked within the situation. Are those calcium scores within stable or unstable? That means, are you inflamed? So you need to look at inflammation and CAC. That, if you're high inflammation and your CAC is going up all the time, that's a problem. If you've basically low inflammation and your CAC is going up to stabilize all that and heal it, it's less of a problem. It's actually a good thing. That's the difference between the two. You've got to understand that sort of situation. It is completely different, one with the other. They're not the same, and it's really important to understand that. Okay, so let's go back to screen 2. Yes, do you remember this one? This one where Michael Greger talks about the 40-year-old vegan dies of heart attack. And he comes up with some spurious things about omega-3s and B12. Absolutely crap and all that. Okay. A taurine supplementation vegan diet may blunt the contribution of neutrophil activation to acute coronary events. Taurine supplementation. So taurine supplementation vegan diet may blunt the contribution to neutrophil activation acute events. Activation coronary during acute coronary events. Unstable angina and myocardial infarction. So basically, however, so the risks go up. These phenomena may help to explain why elevated white cell count has been found to be an independent coronary risk factor. Low-fat vegan diets can decrease circulating lymphocyte, necrophil, and monocytes, possibly owing to downregulation of IGF-1 activity. Thus, relative neutropenia may contribute to coronary protection. They think, and all this, but the key thing is, this is all the propaganda down here, but the actual thing is the unstable angina. And taurine actually plays a role in that. So there are synergies between an animal-based diet that basically, you know, because taurine is one of those things that actually acts as an antioxidant. It actually reduces inflammation in the body, and is really important. And people that are actually highly glycating themselves, so I'd ignore the other stuff because they've got the other stuff. Oh, the diet does this and that. Well, that's just from epidemiology. That's just an opinion, nothing else. The reality is these sort of things are the other stuff. The first stuff that they talk about is mechanistic. It's actually showing taurine having a protective role. Why don't you just talk about that and stop talking about the other nonsense? You know, they have to. They've gotten, you know, academia, bunch of exactly severe tosses. So I like to show that sort of stuff because, you know, I don't hide anything. But you need to know that's, and then all the other garbage that usually, because people always will go, oh, what about this other stuff? Yeah, that's an opinion. They haven't demonstrated mechanism. But when taurine supplementation, they do, in terms of, you know, the effects. So, you know, they're pointing out an important factor, which is non-existent in the vegan diet, which is taurine. So it's really important that we cover these points. But that was just a bit of a swipe at the vagoons that I just wanted to take. But the reality is, you have to understand the difference between soft calcification, atheromas, and highly calcified. So we need to understand that it can be a benefit to us. Really important. Stabilizing the damage that we've caused. Obviously, in normal physiology, living a normal life from a species appropriate diet from birth to old age, you would never get these massive calcified sort of lesions in your body. There'd be much smaller little tears here and there, bit of damage here and there. It would be minor, and the body would just basically, you know, first stitch it up with LP(a), then calcify it, then remove that, you know, the fat soluble vitamins would come in, would basically remove, because these enzymes that would be created, they would remove this soft, small amount of, you know, the lipid core, and you'd be left with a very hard calcified structure there, and slowly it would heal behind, a bit like a scar. It would heal behind, and when it healed, then the body would come away with basically that minoquinone 4 with the right hook, grab it and remove it. Got it? That's what it's supposed to do. That's how it works. And that's why I say, if you're going to do high doses of minoquinone 4, you should always do them in a low inflammatory state. You shouldn't be contributing to more inflammation or more damage. You need to basically bring all the inflammation down, allow the calcification to build up. That means using vitamin D, using minoquinone 4, using, you know, making sure you're getting enough retinol in your diet without going crazy. We're talking about just normal levels, good levels, and all that, and allowing the body to calcify, stabilize, remove the soft plaque, you know, that lipid core, remove it, and then slowly but surely over time, once you've gone, I would say, a year, and then basically then use high dose of minoquinone in a low inflammatory state, minoquinone 4, to remove it and clear out those blood vessels, you know, which are already, you know, healed. That's the important thing. And then, you know, a lot of other things that I will include in my future video to cover some additional hacks and things to do to improve endothelial function and endothelial repair and stuff like that. This was more focused on basically just showing the nonsense that are around this sort of stuff that people are talking about at the moment, who do not understand how physiology works and don't understand that calcification can be a positive thing if it's stabilizing and preventing ruptures. You know, these people that came into this study, they came in from a SAD diet with a lot of soft calcified tissue, sort of endothelial tissue. What they basically got was the benefit of fat soluble vitamins that brought the inflammation down, the diet and then stabilize that tissue with more calcification to prevent potential risks of rupture. It was protective, but not in the way most people would have expected. You've got to understand that the body first needs to stabilize and then it can clear up the debris. So it's a stage, and that's why people need to be patient. But most people, they want the magic pill. I want a magic pill to solve all my problems. Well, it doesn't really work like that. If you've done damage over a number of decades, it's going to take a while to basically repair, stabilize, drop the inflammation, stabilize the with additional calcification, and then remove it in a non-inflamed state. That's how it's supposed to work. That is the natural way it's supposed to work, and that's a way that most people do not understand these natural processes. When they do understand these natural processes, then they don't talk nonsense. So now you guys know why calcification or increases in calcification in a low inflammatory state are not a bad thing. They are actually a positive thing. It's actually a protective mechanism, which you should be thankful that the body does to remove those very unstable soft plaques, which could have the potential of killing people. Anyway, I hope you enjoyed that video. Anyway, another piece of BS in this area, slain. See yous. I just wanted to do just an addition to that video that just to remind people, the last study that I actually showed with the vegan one in terms of the neutrophil activation part, that's just to clarify that for people, that's inflammation. Okay, so that's what's being activated in that regard. So the taurine has an effect on that directly in the system. So that's what that was sort of covering, but also gives a bit of an explanation. But I actually had a bit of a thought about it, and I realised something important that actually will make more sense to people in clarifying the arguments that I'm making here. I'll give you an example. You actually get a tear on your skin, a cut. You bleed, and that tear and that cut on your skin will basically then will immediately initiate a whole lot of processes that will clotting factors that will move into that, will clot the blood in that area. LP(a) will be upregulated, it'll stitch it all together and tidy it all up. Then what the body does is it brings in calcium, it pushes calcium into that area. Why is it doing that? Because otherwise that scar tissue there, you can't actually build the scar tissue. That there is basically like soft plaque. It's the equivalent of the outside version of it in a sense. So, then it will basically, build up a very thick, tough skin layer. All the fiber and the calcium and all that will build up a very strong sort of structure to basically allow that. And once it heals, then the body will clear all that up, all that debris. And if you notice, if you've got an injury and you're very sick, you're very unhealthy or whatever, it takes a long time to heal. Well, the same thing's happening in your arteries. If you're basically continuously putting shit in and inflaming, it's like scratching. I'm scratching, I'm inflaming it continuously. It doesn't really, tie together and heal properly. It doesn't basically bring in all that fibrous material with the calcium and stuff like that, the equivalent, what's happening in your arteries, to sort of stabilize all that. It's constantly being inflamed. You're constantly scratching it, taking in seed oils or whatever. You're constantly inflaming that area. So when you actually bring down inflammation on a low inflammatory diet, and you're healthy, as an example, you're not very inflamed, very sick and all that, you heal faster. You heal a hell of a lot faster. Well, the same thing's happening in your body, in your arteries. Once you take down the inflammation, it will calcify quickly. Then the body will actually take all those soft lipids out. It will stabilize, it will heal behind, and then in a low inflammatory state, well, initially you'll calcify to stabilize, you know, that atheroma from being potentially a risk factor to basically erupt and cause a rupture inside, which will kill you. It's called a cardiovascular incident, a heart attack or a stroke. Then that sort of will be cleared away. Traditionally, that would have happened in a human in a very simple way. You would have not had that level of inflammation continuously going. But a bit of injury or whatever, a bit of LP-little-a stitching it all up, then the calcification there, and then eventually the body uses fat-soluble vitamins, the enzymes that are basically produced by retinol and vitamin D, and then minoquinone 4 or vitamin K2 will basically activate those specific types of enzymes, and they will go in there and latch and remove all that sort of stuff eventually. Now, obviously, this is the reason why I'll be discussing about dosing and stuff like that in regards to my cardiovascular reversal and decalcification and stuff like that. But first, you need to stabilize things before you start removing them, and the body knows best. It's not, you know, you bring down the inflammation, you're no longer adding to this inflammatory state and damaging that area, that tissue where your LP-little-a has to come in and, you know, and sort of try to stitch it all up and hold it together. Eventually, you start putting a bit of calcium in and putting more to stabilize it. Once that stabilization happens, it's no different than the scar tissue. Once you stop the scratching or the inflammation, that will sort of heal over and seal, and then basically the body will just remove all that debris, get rid of it eventually over time when that heals beneath that debris. It's the same thing that happens. Calcification is not a bad thing. It's basically a protective mechanism to stabilize so you don't get any ruptures, or you do not want soft plaquing. You do not want stuff that can actually rupture and could potentially create a whole lot of streaks and a whole lot of mess inside your arteries. You want that held together, stitched up, then calcified, and then the body, once that's healed, because you're not assaulting it with any more inflammation, then it will remove all that. So these people that will put on a carnivore diet and tested, basically what the body was doing exactly. It came down the inflammation, it stabilized that by calcifying it more. That's what's supposed to happen. And if they stay on that diet for long enough and put in the right sort of foods that are rich in those fat-soluble vitamins, eventually the body will start clearing all that out in a low inflammatory state. That's what it's supposed to do. So just to clarify a few of those things, just in case they weren't clear for people, to avoid multiple questions being asked right after, that's what's really happening. And that's why we see that 40-year-old vegan having cardiovascular disease, why that person, and there's going to be more of these people, you will see. Now that they're on their SAD diet, vegan SAD diet 2.0, where they're engaging in the Randall cycle, these people are going to be really unhealthy, even compared to SAD dieters. So traditional vegans didn't basically just waste it away, but they didn't engage the Randall cycle. But the modern day ones that are eating all this sort of processed garbage, or even SAD dieters, a transition to an all, you know, plant-based kibble eating approach, they will suffer worse outcomes because of lack of taurine in there, and lack of the fat-soluble vitamins that actually have that protective role. You know, that's what we're going to see, and it'll only be a matter of time. The problem is, disease can take a decade or more, so it will take some time before we actually see these things. But we will see an escalation in these sort of outcomes in this sort of community. Anyway, I just wanted to clarify that sort of stuff, just so it's clearer what's actually happening and the process of that. Hopefully that sort of covered those few areas that may not have been clear from the initial part. So hope you enjoyed this video. Thanks for watching.